Hello, everyone. Welcome to the fourth and last episode of Monster Mash Mondays. I'm Dr. Naim Alkhouri, the Chief Medical Officer at Arizona Liver Health. We are a large hepatology practice where we provide standard of care treatments and clinical trials for patients with chronic liver diseases. I am joined today with my dear friend, Professor Alina Allen. Dr. Allen, please introduce yourself to our audience.
Hello, Dr. Alkhouri, and thanks for having me. I am Alina Allen. I am the director of the Mayo Clinic at Mayo Clinic in Rochester, Minnesota, and I'm very happy to be here to discuss the non-invasive testing in FAASLD.
Thank you for joining us. So, Dr. Allen, tell us about these non-invasive tests that you utilize in your clinics on a daily basis to risk stratify patients with MASLD and MASH.
So I think for the types of non-invasive tests, I think of them in two categories. One is blood-based testing and one is imaging-based. And I'll start with blood-based testing. The first and the easiest and the most accessible one is what we call FIB-4 score, which has been developed to identify patients with advanced fibrosis. And this is a simple score that uses four components. One is the age of the patient, and the AST, ALT, and platelet count. That is very, very easy to use using the regular calculators or even in electronic health records. These other blood-based tests that are commercialized and available in practice are enhanced liver fibrosis score or ELF score, which is also a marker of fibrosis. There are several other blood-based tests that are designed for either inflammation or for fibrosis, but not used in the daily practice as of yet. The second category of imaging based tests are what's called elastography, which are ultrasound based elastography measures such as FibroScan, the most commonly used method of elastography, which can be used in the office. It has an ultrasound-based probe, provides the number of the two measures, one of steatosis and the other one of liver stiffness, which corresponds with scar tissue or fibrosis. The other type of elastography is magnetic resonance elastography or MRE, which provides the same numbers of fat and liver stiffness and is the most accurate test, the closest we can have to histology if we were to perform a liver biopsy in these patients.
Well, this is excellent news that we have several NITs, non-invasive tests that we can utilize. As you mentioned, Dr. Allen, these are the most commonly utilized ones. We have other serologic-based ones, including the massive owl liver test. We also have the liver fast test, and potentially in the near future, we'll have the NIS2 plus and maybe ProC3. And then on the imaging side, we have several other technologies that can measure liver stiffness, identify the stage of fibrosis, and look at liver fibroinflammation and also liver fat. So this is good. So tell us, in primary care clinics, in endocrinology clinics, where they have a high volume of patients with suspected MASLD and MASH, how do you recommend they utilize these tests to decide which patients are high risk and they need to be referred to a gastroenterologist or a hepatologist?
The algorithm is outlined in this slide, and I'll try to simplify it by saying start with what there is available at each individual's institution. The ideal state is for everybody to perform some sort of fibrosis estimation with elastography, which is the most accurate of whichever form. But in cases where this is not available in primary care practice or endocrinology or obesity medicine clinics, the easiest way to start is by identifying who is at risk. Who are those patients in whom we should think that there could be liver fibrosis? And the most important one, if there's one message I think from this session, would be to consider those with diabetes, because those are the people who are the most likely at risk for having fibrosis. 2/3 of these patients have excess fat in the liver. Up to 1 in 5 can have scar tissue that is clinically significant. So diabetics should be screened. The other category would be patients who have excess weight or obesity and another metabolic risk factors such as high blood pressure, dyslipidemia, um, hypertension, and so on. And then the other category is those who have incidentally found excess liver fat on imaging performed for other reasons. So, in these people, we should start with the basics. FIB4 would be the first line that is recommended by professional societal guidances, simply because it's easy to calculate. It is using routine measures such as the aminotransferases and the platelet count. And what we see here on this graph is the cutoff to remember is 1.3. Anyone who with a FIB4 score of less than 1.3 is very unlikely to have clinically significant fibrosis. There are some caveats. It's a little bit less sensitive in those who are very young, but that would be a first line to start with. The negative predictive value of this test in a general population is pretty good. Anybody with a FIB4 of 1.3 or higher warrants further evaluation. And as I said before, ideally, this should be with an elastography technique of any sort from the ones that we mentioned. And that can be done either before referral to a liver specialist in an ideal scenario, or if there's nothing available, they're referring them to a center where these elastography techniques are available is also to be considered. If FibroScan is available, the cutoff that we should remember is that of 8 kilopascals. Anybody with a liver stiffness measurement lower than that is pretty unlikely to have clinically significant fibrosis. It can be monitored in primary care or non-hepatology. And a liver stiffness score of more than 8 warrants referral to specialty care. If ELF is available, which is the other blood test that is recommended for second line evaluation of scar tissue, the cutoffs to remember in most of the guidances are 7.7 or less. Again, that's a pretty good chance that the person does not have scar tissue. Anything higher than that needs to be referred to hepatology for further evaluation. These cutoffs are just a caveat, are still under very deep research and discovery. So what we have now may change in the future, but for now, these would be important to consider for the specifically the question of risk stratification. Should we refer the patients or should we not?
Yeah, thank you, Dr. Allen, for this concise summary. I think one of the messages, as you said, if you have type 2 diabetes, please know your FIB4. This is the least you can do to check on your liver health. And then, of course, if you have access to FibroScan, MR elastography, it'll be very nice to know the fibrosis stage. Okay, so now we have a high-risk patient coming to you in hepatology clinic, and you need to decide if they qualify for the available pharmacologic treatment. And we all know that since March of this year, now we have the first FDA-approved medication for patients with MASH and F2 fibrosis and higher, and we anticipate to have potentially other drugs in the near future. So how do you decide who's eligible to be treated with new pharmacologic treatments?
Great question, and I think it's really important to understand who. I think from my perspective, it's very important to understand who should not get this therapy. So I'll start with that because the discussion could be a little bit more detailed for those who would be candidates. So this medication, as you mentioned, is approved for moderate to advanced fibrosis, which means that those who have advanced disease, such as or end-stage liver disease, such as cirrhosis, or even worse, decompensated cirrhosis, are not, as of now, candidates for that treatment that is under study in that patient population. So for safety reasons, as of this year, we should do our best to avoid that population. What does that mean? Any sign of cirrhosis on cross-sectional imaging, so evidence of nodular liver, enlarged spleen, or any portosystemic collaterals or portal hypertension. If we do have elastography measures, there are some cutoffs that are really nicely outlined in the most recent guidance from AASLD, and those are 20 kilopascals by FibroScan or VCTE and 5 kilopascals or more on MR elastography. If they have concomitant active liver disease, so anything beyond MASH, such as autoimmune liver disease, alcohol related liver disease, not tested in that population yet, so it should be avoided. Anybody who uses alcohol in excess, and you have the cutoffs listed here on this slide, more than 20 or 30 grams per day for women or men, respectively, or those who have active thyroid disease, because this is a thyroid hormone selective liver receptor agonist. So once we understand that we excluded this with whichever measures we have, then who should we absolutely have a green light into treatment? Those in whom non-invasive tests for sure categorize these patients within that moderate to advanced liver disease. And the guidance by elastography are 8 to 15 kilopascals by VCTE or FibroScan, and 3.1 to 4.4 kilopascals by MR elastography. If patients happen to have had a liver biopsy, stage 2 to 3 fibrosis is again a very strong consideration for this medication. For those in whom these cutoffs are not very clear, then we have to individualize based on the patient, and discussion with the specialists, discussion with the patient is necessary. Sometimes we need more than one or two non-invasive tests to really confirm that that's where the disease stage is. But these are the big picture guidances that I think are very easily accessible by any gastroenterologist and hepatologist who may treat these patients to refer to.
Yeah, thank you, Dr. Allen. I think I just want to clarify a couple of issues with these recommendations. Active thyroid disease does not mean that if you are stable on thyroid hormone replacement therapy that you cannot be on resmetirom. In fact, about 14% of patients in the Maestro-NASH phase 3 trial were on thyroid hormone replacement. So as long as the disease is under control, you can be treated with resmetirom. We also have some small data set showing that patients with kind of moderate alcohol consumption may actually respond the same way as the traditional patients with MASH to resmetirom. So this is a new category we call MET-ALD, and we've presented some data on 75 patients with potentially MET-ALD that were treated with resmetirom and had similar response on fibrosis regression and MASH resolution. And then, as you said, in that kind of yellow zone when we're not sure, I think, having liver stiffness between 15 to 20 kilopascal or MR elastography between 4.4 to 5 kilopascal, these patients can be treated as long as their platelet count is normal and as long as they have imaging showing a smooth liver contour, no evidence of cirrhosis, and no splenomegaly. And I don't want these patients to be missed from treatment just because they have the highest unmet need, and most likely they have F3 fibrosis, but they are not cirrhotic, and we have a narrow window to get them on treatment. But I think this is a very nicely done update to the guidelines. I hope this provides reassurance to other, hepatologists, gastroenterologists, that we can utilize non-invasive tests to appropriately select patients that are good candidates for resmetirom and hopefully in the near future other medications. All right, well, this was a lovely discussion, Dr. Allen. Any last words you want to leave the audience with?
I would end with the initial point that I made, that patients who are at high risk of this disease are those with significant comorbidities that are in the metabolic spectrum. We can do a much better job at screening and identifying these patients. I think this is where the current biggest gap is. There are medications, there are ways to help these patients, but we need to educate our colleagues that we need to look and find these patients who could be candidates for treatment. So that's my parting message: screen, risk stratify.
Thank you. So I also want to leave the audience with my message for 2024, which is just do something for patients with MASLD and MASH. And I like the three S's. So S number one is screen high-risk patients. S number two is stage their disease and know if they have significant fibrosis. And S number three is start treatment in appropriate patients. So with this, I'd like to go to the next slide. If anyone is interested in finding more MASH CME activities, please visit the medscape.org website. They have a few nicely done MASH and MASL related CME activities. Thank you, Dr. Allen. Again, thank you, Medscape, for doing this series in the month of October to raise awareness about MASLD and MASH and highlight all the new advancements in non-invasive testing and therapeutic options for these patients.
Thank you for having me.